Hello, I'm Abdul. It is one of the video in this series and UTI, and it is about management. So in this video, we will be discussing management of UTI. So, for instance, if children present to you in ED, you perform a dipstick. So if nitrate and X-ray is positive, you can straight away start antibiotic, and then you can send culture. Similarly, if nitrite is positive only and leukocyte trace is negative, again you can start antibiotic. If esterase is positive only and nitrites are negative, then as per NICE guideline, the recommendation is do not start antibiotic, and meanwhile you can send a culture, and then you can decide. But if there are strong clinical indication that yes, it is UTI, then you can start antibiotics. So what is the antibiotic of choice and what's the duration? It actually depends on the type of UTI. But before discussing that, if leukocyte esterase and nitrite are negative on testing, it's very unlikely that this is a UTI, and all diagnosis should be sorted. So we were talking about the antibiotic of choice, and in this case we have lower UTI or cystitis, or in afebrile UTIs, we usually the choice of antibiotics trimethoprim, sulfamethoxazole, or only trimethoprim and nitrofurantoin. Duration is from 3 to 7 days orally. They are given orally, and 7 days is preferred because of the long-term bacterial clearance is high with the 7-day course as compared to 3-day course. Alternative for cystitis or amoxicillin and cephalexin, but amoxicillin should be started only if there are known sensitivity, local sensitivity, because microbial resistance to amoxicillin is too high. In case of phylonephritis, or say in a febrile UTI, either it may be cystitis or it may be pyelonephritis. So but it's very hard to differentiate between the two, and if in any febrile UTI there is a chance to develop pyelonephritis, so we have a different course, and the antibiotic choice actually changes as per NICE guidelines. Cephalexin and carmaxiclo are the first choices, and as per NICE guidelines, 7 to 10 days course is sufficient, but some studies say that now 14 days will be likely, is preferred. If the child is too sick to take because he's vomiting or he's dehydrated, then we can use amoxiclav, ciprofloxacin, ceftriaxone, gentamicin, or amikacin. These are the choices, and usually 7 to 10 days of course is recommended dose. Despite of the saying these recommendation, and so you have to look for certain other thing, as if you start them on antibiotic and then the culture result is available, you can change antibiotic as per culture report. You should know local microbial resistant patron, and then as per recommendation, local guideline, you can use different antibiotics. Previous culture report on the same patient may be a good indicator to use it as a culture sensitivity for to predict the culture sensitivity on the sample that you have sent. Pseudomonas aeruginosa is usually not covered by cephalosporin intergenation, so fluoroquinolone is the choice. And safety profile is still in question for fluoroquinolones in children, but it can be, if the culture report is not sensitivity is not available in the culture result in Pseudomonas aeruginosa, fluoroquinolone can be started. Ciprofloxacin is one of the choice, and just another important will be levofloxacin, an alternative for ciprofloxacin. and it has been also a very important, it has a low side effect profile, so it can be used. I wanted to emphasize on this point that urine culture are typically negative within 24 hours of initiation of antibiotic therapy, and so if you send a culture during therapy, it's very almost always negative. Here I have specifically wanted to talk about acute lobar nephronia, renal abscess, and perinephric abscess. What are the antibiotic of choice, and what are the management guideline for it? So the antibiotic that we say, the IV ceftriaxone or cefuroxime or gentamicin or coimoxicillin, that can be used, but the duration is 14 to 21 days, so this one difference. And if you use it for shorter duration, there are chances that there will be treatment failure. Similarly, we have children which have renal or perirenal abscesses. They will need surgical or percutaneous drainage in addition to antibiotic therapy and other supportive therapy. So what is percutaneous drainage recommendation? Normally it is done before surgical intervention, and it is recommended if the abscess is larger than 3 to 5 centimeters. So sometime a clinical trial may be given, such as a 48-hour trial may be given in children. In abscesses which are smaller than 3 centimeters, what happened that they should be treated with antibiotic alone. And there are studies that instead of IV, we can use actually oral antibiotic for renal abscesses, because we are already using a oral antibiotic in other invasive infection like osteomyelitis. So taking from that experience, now there are certain abscesses that maybe and it can be treated with the with antibiotics, oral antibiotics. So normally for a renal abscess, what will happen that you will get 1 to 2 weeks of IV antibiotic, and that will be followed by 2 to 4 weeks of oral antibiotic. That will be focusing the 2 E. coli and Staph aureus that should be on the target. And the loss of there's another important point that we can lose in 10 to 20% of cases we can lose a kidney. In perinephric abscess, again, IV antibiotic or the choice, and if the area is large or renal function are deranged, then we can use percutaneous drainage, and percutaneous drainage has this extra benefit of identifying the identification of causative organism. This is another important and still under a lot of discussion, that is the other potential treatments, and that is this is like a probiotic which will replace the urogenital flora, and cranberry juice has been also implicated in prevention and treatment of UTI. There is a non-uropathogenic E. coli. It doesn't cause, so it is an E. coli strain that doesn't cause any infection. It's called Nizzle. In 1917 it's available in Europe, and this can be used as to inhibit the growth of other bacteria. Similarly, cranberry juice has seen to prevent bacterial adhesion and biofilm formation, and it do so by proanthocyanidine pathway, and so it has recommended to be used by certain authorities, but it is not yet proven. Efficacy is not yet proven. So we have this is a general treatment guideline, so and I wanted to share it to you from the textbook also. So in the next lecture we will be talking about imaging. I have already one video that is available imaging schedule as per NICE guideline, but I will be making and comparing the different recommendations for imaging studies and its role in the diagnosis of UTI and actually the prognosis of UTI. Thank you so much.